episode 1 of PathoLab, and today's episode is about myocardial infarction. I'm Dr. Lisa Ahmati, student in Tehran University Medical Sciences, and we're going to dig deep into what myocardial infarction is. First, let's start with the definition of myocardial infarction. MI is a type of necrosis in your cardiac muscles that is due to prolonged severe ischemia. The first thing you need to know as medical students, and therefore as future doctors, are the risk factors of myocardial infarction. Now, this first risk factor that we're going to talk about is race. White people are more prone to myocardial infarction than black people. Also, Indians have shown a higher risk of MI. The second risk factor that has been concluded is age. Myocardial infarction raises progressively with age and reaches its peak at about 40 to 65 years old. However, you may have young patients with MI as well if they have a risk of hyperlipidemia, hypertension, smoking, and diabetes. The next risk factor is gender. Males actually have a significantly higher risk to myocardial infarction than females in the reproductive area. However, after menopause, this risk is the same as males. The protective effect, let's say, that females have has been believed to be estrogen. Now that we know what your patients of myocardial infarction would look like, let's take a look at the etiology, or why MI happens. Now, in 90% of the cases, atherosclerosis is the cause of MI, and I'm sure you all know about it, but I'm going to just say it briefly. Atherosclerosis is the tightening of the vessels of one or more than one coronary arteries, which will result in that necrosis we talked about. And because it's very common, I'm sure as med students, you all know about it. Well, what about the other causes of myocardial infarction? Emboli can be one of the reasons, and there can be two things that may occur to emboli. I'm going to read it off my pamphlet. The first thing that may occur to emboli actually is vegetations of infective endocarditis, which is basically when you have some kind of bacteria, immune cells, platelets, and fibrin all getting clogged in your vessels. The second thing that may happen is actually called in cardiac prosthetic materials. Let's say the artificial things, implementations you may have in your vessels or your heart. But ischemia itself can also have other reasons. For example, let's say vasculitis hematologic reasons like the sickle cell anemia that I'm sure all of you know about. Or for example, the deposition of amyloid beta inside the vessels, which can actually make a lower blood pressure. Now that we know the etiology of myocardial infarction, let's take a look at the pathogenesis of MI. How does atherosclerosis result to MI step by step? So you already have an atherosclerosis, let's say a pre-existing atherosclerosis in your arteries, or what I may call an adequate or inadequate coronary infusion. You don't have enough oxygen to a part of your heart. Now, in this stage, if you have a sudden thrombosis, an acute change in your plaque, or what he likes to call a superimposed plaque, you will have stage 1 of MI. Now, what I talked about would be really hard to understand, so I will make it step by step. Now, in the step 1, it's a sudden change of event in your plaque. Let's say you have a coronary vein with a pre-existing atherosclerosis, a pre-existing plaque, that you can read about it if you want to and go review that. But now we're going to have an acute sudden change in it. This change can be rupture. This change can be the tearing apart of the plaque. We're going to talk about this acute changes a little bit more. These changes can be, let's say, erosion or oscillation of the plaque, or a hemorrhage into the center of your plaque. So you basically have a plaque, you have your hemorrhage into the center, which makes your plaque actually get bigger and bigger, and due to time, it will actually oculate the whole length of the vessel. Now, these changes can be intrinsic or extrinsic. Let's say the intrinsic factors. There can be some plaques can actually have a shape that will make them more vulnerable to these acute changes. We actually call these the vulnerable plaques. We also have some extrinsic factors like high blood pressure or those hemorrhagic factors that we talked about. Now, this acute change in a pre-existing atherosclerosis plaque was step 1. Let's go to step 2. In the second stage, you have your microthomies come and aggregate in the place you have this acute change in plaque, and they try to aggregate fibrins all around it. In the third stage, however, your immune system is actually working against you because your macrophages are putting a layer around your plaque, making it bigger and bigger until it occupies the whole length of your vessel, resulting to an MI. So until now, we've learned the definition of MI, the risk factors of MI, etiology, and the pathogenesis step by step. Now we have to know more about it. We will go to the second part of the video where my friend will explain more.
Hey guys, welcome to the second part of episode 1 of PathLab, Myocardial Infarction. I'm Dr. Nigin Khazi, a student at the Tehran University of Medical Science. So we are going to pick up where we left off. Now this part is so important because we're gonna talk about how to diagnose myocardial infarction. We will diagnose based on 3 things: clinical symptoms, electrocardiographic changes, and laboratory findings. Let's talk about clinical symptoms. You will have severe chest pain that can also radiate to the neck, jaw, epigastrium, or left arm. Rapid weak pulse, profuse sweating, dyspnea, or shortness of breath due to impaired contraction of the ischemic myocardium can be the other symptoms. In about 10 to 15% of cases, they could be completely symptomatic, which is mostly common in apelin patients or patients with diabetes mellitus. Now that we have learned about the clinical symptoms, let us move to electrocardiographic changes. This video's purpose is not to teach you what an electrocardiogram is, but if you need to understand the 3 points I will make, so please go ahead and review it for yourself. The 3 changes that happen to an electrocardiogram are: number 1, Q waves; number 2, ST segment changes; and T inversions also change. These findings are mainly due to leakage of proteins from the necrotic myocardial cells into the blood circulation. The first thing is cardiac troponin. As you know, these proteins are involved in heart muscle contraction, and the increase of plasma cells of this protein may establish the diagnosis of myocardial infarction. The cardiac specific proteins are 2 types. Troponin I and T. They are the most sensitive and specific marker for myocardial infarction. Levels began to rise at 2 to 4 hours and peak at 48 hours. The elevated troponin levels may remain for 7 to 10 days after acute MI. The next thing is cardiac creatine phosphokinase. It's a non-specific enzyme marker and is presented in brain, myocardium, and skeletal muscles. It has 2 easier forms, designated M and BMB, mostly in cardiac muscles. This MB form is sensitive but not specific because it's also raised with skeletal muscle injury. The level rises within 2 to 4 hours and peaks at 24 hours and returns to normal within 72 hours. The next marker is LDH, or lactate dehydrogenase. It's not a specific marker and it starts rising after 24 to 48 hours and it remains for many days and returns to normal in 7 to 14 days. The last laboratory result is myoglobin, which is an oxygen-carrying respiratory protein found only in skeletal and cardiac muscles. It is the earliest marker of MI. The level rises within 1 to 3 hours and peaks in about 8 to 12 hours and returns to normal in about 24 hours to 36 hours. Now that we know how to diagnose myocardial infarction, let's know about the first 72-hour complications this disease will result to. The first complication is a cardiogenic shock followed by conductive disturbances or arrhythmia, followed by acute pulmonary edema resulting from left ventricle failure and the ruptured external hemopericardium. Now you can see in this picture how in the onset and the earliest 72 hours, the infarction of the left ventricle results in a rupture of pericardium and acute pulmonary edema. Now until here, in the second part of the video, we have learned how to diagnose myocardial infarction based on clinical symptoms, electrocardiogram, and laboratory results, and also learn what to look for in case of complications in the first 72 hours of your patient. Hope this video has helped you understand recurring pathology better. Thanks for watching and see you guys in the next video. Bye!